Oh, hey everyone, I'm Cassandra Agenor. I'm the current medical director of Brooklyn SART, and today I'm going to be talking about a topic that results in about 48,000 deaths in the United States annually, and even more specifically, 132 deaths per day. And it's actually the second leading cause of injury-related deaths in NYC. So it's something we see quite frequently in CCT, which is gunshot wounds. So today I'm going to be talking about how to sort of address gunshot wounds in the emergency department. First, I'm going to start with talking a little bit about firearms in general, ammunition. Then I'm going to jump into wound ballistics specifically, and then how what we document in our charts can help forensic specialists sort of identify the weapon that was used and the range of fire, at what distance was the weapon actually discharged, and how they can determine entrance and exit wounds based on the information that we document. And then I'll end with sort of like the do's and don'ts with documentation. So just the basics of firearms, we have four basic structures, which is the grip, the trigger, the hammer, and the barrel. So when the trigger is pulled, the hammer strikes the firing pin, which is right against the base of the cartridge, and then that ignites the primer, and the primer then ignites the gunpowder in the cartridge case, and then the bullet propels down the barrel and exits through the muzzle. A lot of guns or firearms in general have this sort of mechanism called rifling, which basically results in a rotational spin, and it stabilizes the bullet as it exits the muzzle. So basically, as the bullet is carrying out throughout the air, traveling through the air, it prevents it from tumbling. But this has no impact on what happens inside the body or what happens inside the intended target. A lot of times bullets will begin to yaw, which is basically when it starts to rotate off its axis. And it could do a lot of damage at that point, especially if it flips a total of 180 degrees forward. Some of the things that are labeled here, you see the grooves and the lands. When you think, if you ever heard of caliber, when they talk about caliber in regards to firearms, that's just basically measuring from one land to the other. So some of the common firearms we'll talk about today is handguns, rifles, and shotguns. What we tend to see more in the urban setting are handguns, because they're smaller firearms, they're easily concealable. Then you have, and they're all rifled barrels. So it's created to sort of stabilize the bullet as it's exiting the muzzle, as I mentioned before. They're all low velocity and low energy, which means that they tend to cause less damage than those that are higher velocity and higher energy, but that's not always the case. So if you look at these two pictures, you have two different kinds of handguns, which is a revolver versus semi-automatic. It's basically in the name. Revolvers, they have a cylindrical sort of revolving container for the bullets. Usually it can hold about 6 bullets at a time, whereas a semi-automatic has an actual magazine that gets loaded into the grip, and that could hold anywhere from 7 to 15 bullets. Then you have rifles. Just like it says in the name, they have rifled barrels, like I described earlier. But the only difference between a rifle and a handgun is that they're longer. That's one of the main differences. So harder to conceal walking down a street in Brooklyn. And then you have differences in different rifles. You have center fire rifles, which we tend to associate more with machine guns. And then you have rimfire rifles. And again, it's sort of in the name, basically the center fire versus rimfire, that has more to do with the primer. Whether or not it's shock activated or impact activated. But even though, if you can see in these pictures, they look very similar, however, they're very different. So center fire rifles, they have high velocity and high energy. So these particular types of rifles, the bullets that are used tend to be semi-jacketed or full jacketed. And I'll talk a little bit about what that means a little bit later. And then you have assault rifles, which is a center fire rifle, which is what we tend to think of in the military when there's a use of machine guns. And that specifically is auto-loading. It has large capacity, and it has detachable magazines that tend to be full automatic fires. So it can do a lot of damage, especially in an open crowd. Rimfire, like I mentioned before, looks very similar if you look at them side by side to center fire, but it's actually low velocity. So despite the fact they look very similar, when we look at the patterns that they'll form on a physical body, they're actually their patterns are more similar to that of a handgun. Shotguns, we're not going to talk too much about shotguns today, but shotguns tend to be used quite frequently for hunting. They have long, smooth bore barrels, so these are not rifled. So which means that the bullets, as they're exiting, the actual muzzle is less stable. And they tend to be, for the most part, low velocity. But despite the fact that they're low velocity, they tend to do a great deal of damage. And the reason for that is that they tend to fire multiple projectiles. And not only that, but if they're shot at close range, especially close to individual's face, there's a lot of this blast effect as well. So it could lead to very severe traumatic brain injury. Now, a little bit about ammunition. When you think about ammunition, you think about a cartridge, it just goes hand in hand. A cartridge is, as I mentioned before, it tends to be determined by the caliber, which is when you're measuring from land to land, like in the muzzle or in the barrel itself. But every single cartridge contains these 4 components. The casing is what we tend to think of when we're watching a show and there's like casings all over the crime scene on the ground after a firearm has been discharged. Then you have the primer, which is a chemical that basically gets detonated. Like I mentioned before, it could be shock related or it could be impact related, but there's different ways of detonating a primer. The primer then ignites the gunpowder. And the gunpowder is what propels the bullet outside of the muzzle. There are different forms of bullets. When we tend to think of bullets, we tend to think of lead bullets because we tend to think about lead toxicity, especially with pediatric patients. But we don't tend to talk a lot about semi-jacketed bullets and full metal jacketed bullets. Basically, it's in the name again. A lot of these, the way they name these things are very simple. Full metal jacket means that it has a full metal jacket, usually made of copper. And the reason for that is that a lot of the weapons that have are actually high velocity, when the bullet is exiting the muzzle, it can get deformed. So it requires a full metal jacket to sort of protect it so it doesn't deform before hitting the actual target. And then semi-jacketed means that it's not fully jacketed. So it does have a copper covering. However, the lead core is exposed at the tip usually. So one thing to keep in mind is that even though they're jacketed versus semi-jacketed versus full jacketed, they have lead at the core. Okay, so can still lead to lead toxicity. And there's different forms of specialized bullets. Some of the pictures I show here on the bottom left is a shot shell, which is also called a rat shot, which has multiple little pellets inside of it. Then you have adjacent to it is the frangible bullet, which means that upon impact, it sort of disintegrates, completely breaks apart, which tends to help with issues with being in a crowd and with ricocheting that could cause additional injuries. Well, this one just completely disintegrates. So that sort of avoids that situation. And then you also have flechettes, which is next to it, which almost looks similar to an arrow. So when you look at these wounds, the history that you get from the patient is extremely important because if they said that they've been shot at, believe they've been shot at, it might not look exactly like what you expect it to look like. It might not look like a circular wound, which is what we tend to expect. So now specifically, we're going to talk about wound ballistics, but even before getting into that, there are different forms of ballistics, which I sort of described earlier, but I didn't put a name to. So you have internal ballistics, which is when the bullet is inside of the actual firearm and it's making its way out. Once it makes its way out and is traveling through the air, that's called external ballistics. And then now we're talking about terminal ballistics, which is when the actual bullet hits the final target. In the case when it's actually a human being or a human body, we call that wound ballistics specifically. So terminal ballistics, wound ballistics, for our purposes, is the same exact thing. So what determines the kind of damage that's done to the actual human body based on, as I mentioned before, is based on the weapon that's used and the velocity of the bullet as it's exiting the muzzle. So what we tend to think of when it comes to that is there's 2 components that is important when it comes to kinetic energy, and that's the mass and the velocity. The mass for bullets, for the most part, they tend to be very small, doesn't have that big of an impact, but if you double the mass, of course, you'll double the kinetic energy. But when it comes to velocity, just by doubling the velocity, you could quadruple the amount of energy and the amount of damage that can be done. For most sources that you look at, they'll tend to say low velocity versus high velocities, anywhere like less than or greater to 1,000 feet per second, but some will also use 2,000. So it varies a lot. But like I mentioned before, handguns, for our purpose, in general, low velocity, low energy, whereas rifles, machine guns, high velocity, high energy. When we're looking at specifically gunshot wounds, so the extent of the injury from the bullet is usually to a couple of different things. First, what we tend to think of automatically is when the bullet actually perforates the skin. And that's what results in the shredding and the crushing of the actual tissue. And that forms a permanent cavity within the body. But what we don't tend to think about is the temporary cavity that's actually created as the shock wave from the bullet travels through the body. So which means that areas adjacent to that permanent cavity actually get damaged. So you have sharing of blood vessels, nerves, and organs adjacent to the path of the actual bullet. So we have to consider that. So we might be able to say, oh, maybe the trajectory is right, it went right through the arm, and now the other arm, I think we're fine, it's not going to be an issue, but there actually could be several major vessels and nerves that are damaged. And at times, even from a temporary cavity, you can actually result in broken bones, but not as commonly as a permanent cavity. And then of course you have secondary injuries, which is when the bullet actually breaks apart, and that could result in injuries. As I mentioned before, there are different types of gunshot wounds. You have the penetrating, which is when you tend to see like one wound. It goes in, but you don't see anything coming out. You have the perforating, goes through one side, out the other. You have re-entry, where it goes in one way and out the other, but then it goes in again, but you don't see another wound. So you only see 3 wounds. And then of course you have grazing and tangential, which is when it sort of like causes abrasion on the skin, but doesn't actually fully penetrate. So this is just sort of like an image. I sort of talked about the temporary cavity versus the permanent cavity, which you can see here. So if you look at the permanent cavity that we tend to think of when we think about the trajectory of the bullet, it sort of goes in. And despite the rifles, like I mentioned before, the rifling helps stabilizing the bullet. Once it's inside the body, rifling does not help whatsoever. So the bullet can easily tumble, and then it creates a shock wave, and that creates this temporary cavity. So this cavity, even though it may initially be there and we can't physically see it, when the patient presents to the ED, it can cause damage to adjacent structures. There are some structures that tend to be more damaged than others. So a structure that has high elasticity, like the lungs, for example, or skeletal muscle, they don't tend to be as damaged when it comes to temporary cavities as structures that have less elasticity, like the spleen, for example. A spleen could easily shatter and lead to very significant hemorrhaging without the bullet actually hitting the actual spleen. And that's just from the shock wave. So that's what we have to consider, the trajectory of the bullet and what's adjacent to that area. So in general, when we're thinking about the temporary cavity, we're thinking about the location, the size, and the shape of the temporary cavity, and that could be impacted by the nature of the bullet. Handguns, for the most part, tend to go right in. They create a small permanent cavity, and the temporary cavity is usually really non-existent. But however, a rifle, which is like rifles specifically used for hunting, are designed to expand. So they actually create very large temporary cavities and could cause a great deal of damage. So we have to consider that. And we're going to talk about entrance rooms and exit rooms a little bit later, but just to keep in mind, the path of the bullet will determine the size of the wound, usually, especially with the exit wound. For the most part, we tend to think that entrance wounds are smaller than exit wounds, but that's not always the case. If you look at, you're looking at this image here, where the bullet is taking the long path of the bullet was a long path for the bullet to exit the body here. And as the yaw occurs, you see that the 180 degrees of the bullet, when it tumbles, is actually right in the center right here. So the largest wound is actually within the skin, which is what we're not going to see. And then by the time it exits, is a small wound at the end. However, if it's traveling a shorter distance, it can actually completely rotate 180 degrees at the end when it's exiting the actual body. So in that case, the exit wound will actually be larger than the entrance wound. So that's why, and I'll talk about this a little bit later, so we should never document entrance versus exit wounds. Just document what you see, and just large versus small, and the actual size when you measure it. In general, when we're thinking about wound ballistics, when we're talking about the wound severity specifically, like I mentioned before, the bullet has a lot to do with that, the caliber of the bullet, the distance, the mass, the velocity, the yaw, like where it actually rotates. And then of course, the tissue, like I mentioned, there's different densities and elasticities, which are extremely important when it comes to wound severity. And then when we're talking about our approach to treating these wounds, and we have obviously the primary injury care, which is with the paramedics. They try to stabilize the patient, bring them into the ED, usually a level 1 trauma center, like Kings County. And then once these patients tend to arrive, we tend to know what to do, right? Depending on the location of the wound, we tend to activate a level 1 or level 2 trauma code. And just in general, there's basic things that we tend to do. Obviously, Tdap if it's not up to date. But then one of the things that's controversial is antibiotics, whether or not you antibiotics a patient or you don't. That's very controversial, but for the most part, we have to keep in mind that I think a lot of people don't tend to antibiotics because they tend to think, oh, the bullet's hot. So there can't be any microbes that could have survived entering the body, but there actually can be. And just like I mentioned before, with the vibrations that occur as the bullet is entering the body, it actually creates a suction, which means that whatever the bullet hit in the process of entering the body, that all gets sucked into the actual wound. So you have to think about, what did it hit? Was there any secondary targets that wasn't intended that it probably struck? What kind of debris could potentially be in the wound? And those sort of things can lead to infection and sepsis. So you have to think about the whole picture and evaluate the patient completely. Obviously, if the bullet goes right through an artery, we have to consider arthrotomies, of course, because it can lead to a lot of local inflammation and higher risk of lead intoxication as well. For the most part, bullets tend to stay inside the body. For the most part, trauma surgeons do not remove the bullets. However, in the case where there's an actual neurological deficit that sort of correlates with cord compression, then surgical decompression and bullet fragment removal is actually recommended. So we talked about like what we sort of do medically when it comes to these patients when they present in the ED, but we didn't really talk about forensically what we can do. Simple things that we can do is like avoid cutting through the bullet path. When you see the path that the bullet took through the clothing, and things like describing what we see is of extreme importance. And not documenting entrance versus exit wound. I'll explain that more later. And also having the nursing staff photo document the injuries, extremely important. And when I say that documentation is important, I'm not saying that it's important for you to interpret what the wound is, just document what you see. Forensic specialists will later on use whatever you document to sort of interpret the distance of the weapon firing, what weapon was used, and whether the injuries actually corroborate with the story that was provided. So range of fire, just in general, when a firearm is discharged, there's a lot of things that come out of it besides just a bullet. So it tends, like in this image here, you'll see a flame tends to exit the muzzle, and it's followed with a lot of heat, the bullet, of course, and then you have gunshot residue, which we sort of describe as soot, right? Like the soot you tend to see with the patient who came into the ED after being brought in after a fire in their apartment or their home. And then you have also burnt and unburnt powder, which will present as stippling, which I'll describe in a little bit. But in general, range of fire, we describe as contact with the muzzle, which is the tip of the gun is actually in contact with the actual skin. Near contact, which is like it's almost there, but not really, like less than 1 centimeter. Intermediate range, which is more than 1 centimeter. And then the last one is no evidence of close range, which is what most people describe as distant range. And that's very hard to determine distant range because an individual can be shot at close range, but they could actually have another object in front of the weapon, and then they won't have the same sort of signs that you'd be looking for with close range, even though it is close range. So we don't tend to say distant range, we just say no evidence of close range, if you forensically at least. So specific things that you're gonna look for, skin findings, right? So just keep it, I'm going to give you both definitely, like sort of like the words that we tend to use, and that if you feel comfortable using, you definitely use, and then just basic words and terminology you use on a day-to-day basis. So first, you tend to have a central defect, which is basically a hole, simple hole, which is usually created by the bullet. Then you have abrasion collar as the bullet is entering the skin. The flame can result in the searing of the skin. So you'll see like burnt edges around the skin, and then you'll even see searing of the hair as well. So regional hairs around the wound, you might see that they're completely gone. Then you have soot deposition, which I mentioned before, is very similar to what you would see with a patient who came in from a fire. And then you have stippling, which is actually unburnt gunpowder. And the difference between what that would look like, soot versus stippling is that soot, just like with a fire victim, you can easily wipe that away. Whereas with stippling or tattooing, it might look black, it might look reddish brown in color, which we'll see a couple of pictures later, but you cannot wipe that away. And that usually takes about days, a couple of days before it actually resolves. And then you can also have pseudo stippling, which is not actually from unburnt gunpowder, and that could be specifically from fragments of bullets as well. And then you have muzzle imprint, which is very common with close or actual hard contact, which is when the gun is directly on the skin. Then all the flame that you're seeing here, all the gas that you're seeing here actually enters the underneath the skin, and then it creates a pressure that sort of goes back against the gun that's held against the skin, and then you end up with a contusion with the imprint of the actual gun. Which is why it's important to do photo documentation, because forensic specialists can use that to determine what gun was used. So now this is just basic terminology for the same thing that I described here. So central defect, you just describe what it is. Round, oval, cross shape, whatever shape it is, you just describe what you see. And then as far as the abrasion color, it's an abrasion. So just say, if you don't remember to use the word abrasion color, just say abrasion, that's fine. And then you have searing of the skin. You can say margin of skin perforation is charred, is a way of describing it. Soot deposition, you can describe that as black dust-like deposition. And then when you touch it, easily wipes away. And then, of course, for the stippling or the powder tattooing, which is unburnt gunpowder, that's just basically, you'll just describe whatever you see, but for the most part, they tend to be punctate abrasions in general. So for the next couple of pictures, I'm just gonna ask for just some participation, just say however you would describe the wounds. But just in general, like I said before, you have close range with contact, near contact, intermediate range. Contact, you'll tend to see soot, right? That tends to be apparent when it's less than 6 inches away, when the gun is less than 6 inches away. And then you have intermediate range, which you'll tend to see stippling, the tattoo, the powder tattooing. And that specifically, you'll see that punctate abrasions. So here for close contact, this is just a couple of these images. All of them here, these are all close contact, so you can see sort of soot. You see them at different locations, so you'll see like soot like directly around this wound here. It's a little bit further apart on this image. In this image, which is actually against a hard surface, specifically a bone. This is like directly into the head. You'll see sort of like the stellate-like defect. And the soot you'll actually see directly in the wound because it's actually hard contact, full contact. So you're not going to see any soot outside. It's going to be actually inside the wound. And then here you can see the muzzle imprint. So key things to document, of course, is shape, size, location. Distribution of soot, is it actually inside the wound? Is it surrounding the wound? And if you see a muzzle imprint, then document that you see an imprint. And just describe whatever you see. You don't have to directly say muzzle imprint. But in general, you'll just see a circular wound with blackened or seared and seared margins. So with this image, how would someone describe this? Anyone want to try? Mm-hmm. Mm-hmm. Okay, good. I think what you're seeing as punctate abrasions is actually specks of blood, but the image is not that great, but I think everything else is absolutely correct. Like you have a central defect and you see like the blackened seared edges, which is like what you're describing as soot. Yeah, yeah. As long as you know it's soot. Like, so if you actually like wipe it away and you know it's soot, say soot. You document that if you on an airway exam for a patient who came in, peri-intubation, you'd say that you see soot in the airway. So that's fine. If you see seared hair, document that you see seared hair. Okay, how about this one? How would someone describe this? You just scream out. How would you describe the defect in the center? Circular, like, right? So, okay, and are you seeing seared edges? Oh, yeah, they're seared edges. And then you have, what's that black stuff? What are we calling that? In the middle, yes, is blood in the middle. Outside of the central defect with blood in it, what are we seeing on the outside? soot. It looks like soot, right? So that's a central defect with seared edges and eccentric soot deposition. And the reason why you'd say eccentric is like it's not completely circular around the wound. And this might not be important clinically, but is important forensically because that could tell us of the direction of where the gun placement was. How about this one? How would you describe this one? Stellate, right? So, there's a lot of tearing of the edges. And this is because if you can tell, I don't know if you can see the eyebrows in the image, but this is right in the middle of the frontal bone. So it's like an irregular stellate appearance with a central defect surrounded by radiating lacerations. And I'm saying lacerations because if you remember lacerations from our sexual assault presentation, lacerations is blunt trauma. It's created by blunt trauma. It's not penetrating. So the actual stellate or like the irregular stellate, like central defect is from the bullet itself. So that's penetrating. But the laceration is from that pressure that sort of goes under the skin and tears the skin because it's actually in direct contact with the gun itself. So it's actually blunt trauma that's resulting in those tears. Okay, how about this one? How would you describe the defect in the center? Okay, so oval, irregular edges. Okay, and what's on the outside? Right, so central defect with surrounding contusion, because you're seeing a little bit of contusion here. I don't know if you guys seeing this redness here on the outside. And then soot deposition and searing of the skin. And I hope you guys know what I mean by searing. Like, does it look like the edges are sort of burnt from the flames? That's what I mean by searing. Now, intermediate range. Yeah, you could describe that. You could say that it's sort of intermediate, it's not continuous, circular. Yeah, soot, exactly. Describe exactly what you see. With this one, intermediate range, where unburnt gunpowder can travel as far as 4 feet, which is what we sort of describe as intermediate range. And so in this picture, what you're seeing here, these punctate abrasions, they're sort of reddish brown in color. Those are actual tattooing or stippling. And for the most part, the further the distance is, then the larger the area of stippling. Whereas like if you're closer, you know, let's say 1 feet versus 4 feet, you'll see the stippling will be closer to the central defect. And it'll be more dense. Whereas when you're further apart, like closer to 4 feet, you'll see that there's a larger area of stippling and there's less density. So here, this one's described central defect with multiple reddish punctate abrasions. Or, you know, once you get more comfortable and you feel comfortable and you feel like you're at that place where you can use the word tattooing, you can easily document tattooing. But for now, I would just describe what it is. I wouldn't even use the word tattooing. So when it comes to distant contact wounds, the firearm is that it's distant from the target. For the most part, like I mentioned before, these are not close range wounds. That's how we would describe it. And the reason why we'd say this is not a close range wound is that we're not seeing the soot, which is usually apparent in less than 6 inches. And we're not seeing the stippling, which is usually apparent in less than 4 feet. So we can basically say this is like greater than 4 feet distance from where the firearm was actually discharged. But this is not something you would document in the chart. You would never say distant, close range. That's not for you to just document what you're seeing, which is a round wound with abrasion ring. Entrance and exit wounds, for the most part, entrance wounds, they tend to be round, oval, but at times they can be atypical or irregular, like you saw, especially when it comes to the bullet going through a hard surface, like the skull. But for the most part, they tend to have basic characteristics of abrasion ring, and they tend to be smaller than the bullet caliber itself. And that's because as the bullet's penetrating the skin sort of stretches and then it contracts afterwards. Exit wounds tend to be irregular in shape. For the most part, they tend to be slit-like. They can be easily confused with like a stab wound, with a knife. So the story, the history that you get from the patient is extremely important. For the most part, the skin tends to be everted. And sometimes you can see protrusion of tissue, especially in the case if you've ever seen a gunshot to the head in CCT. If you see brain tissue on one side, it's more like that's the exit wound side. And as always, do not document exit versus entrance wounds. This is for educational purposes. I'm telling you all of this. And then sometimes you can even see a false abrasion collar. So it may look like an actual abrasion, but sometimes when the bullet hits an area, let's say the patient's wearing a belt and the bullet sort of hits the belt as it's exiting the trunk, then all of a sudden that bullet sort of bounces back into the wound. It could create abrasion collar. So sometimes when you see abrasion collar, it doesn't always mean that's an entrance wound alone. It could be a false abrasion collar. So it's important whatever the story the patient gives you as well. But what you will definitely not see in an exit wound ever is you will never see soot, you'll never see stippling, and you'll never see a muzzle imprint. Like I mentioned, it could be like a slit-like lesion, which could almost look like a knife, like a stab wound. And the edges can be regular, and you'll sometimes see a version of edges as well. It's just like a quick summary of what entry wounds versus exit wounds look like. For the most part, the edges will be inverted for entrance. Exit wound, they'll be everted. You will likely see soot or blackening, burning, tattooing, stippling, all those other things in entry wounds, but you'll never see those in exit wounds. And then of course, you can see tissue actually exiting the wound as well in an exit wound. When it comes to documentation, what you do want to document is you want to document the location, the size, and the shape, which you guys did a great job in doing that today. And you want to document any form of distinguishing forensic characteristics, which is like an abrasion collar. If you see soot, tattooing, stippling, that can't be wiped off, or you see a muzzle imprint, you want to document that as well. But what you do not want to document ever is entrance wound versus exit wound. Because you do not want to be called into court and where the story doesn't match up, and then you're on the stand and they're asking doc, well, how did you determine entrance versus exit? And you don't want to say, oh, one was smaller or larger than the other. Okay, so you never want to document that. And there was actually a study that was in the Journal of Forensic Science. Actually, it was almost a decade ago, actually. And 40% of trauma surgeons got single gunshot wound classifications wrong. That means they inappropriately label entrance versus exit wounds. And that's with a single gunshot wound. But when there was multiple gunshot wounds, 75% of the time they were wrong. Okay, so just keep that in mind. So now let's talk a little bit about NYPD and CCT. When law enforcement, you're basically done in the trauma bay and now you're trying to write your notes or trying to put in your orders. And then you have NYPD coming in. Oh, doc, do you know which wound was the exit wound? Okay. Oh, how far was the gun from the victim? Can you describe the injuries? Does it make sense? Is the patient lying? So a lot of times when we get faced with these questions, it's always a question of HIPAA, right? Like, are we violating the patient's rights by providing certain information? Well, there are actually laws of, there are certain exceptions to HIPAA, specifically when it comes to law enforcement. And I'm gonna talk a little bit very quickly about some of those today. Of course, if there's a court order, where there's an actual subpoena, which is not usually the case acutely in CCT. So you don't have to worry about that. There's an administrative request, which sometimes doesn't come from the court, which is like a written request, which rarely happens as well in CCT. But this is the one that tends to be more specific, which is like something that tends to happen more often, is when the information they need is the information they're requesting may help identify a suspect. And when it comes to that, there is certain information that we are required to provide, even without written documentation or request. And obviously, if the victim agrees, then a victim of a crime agrees, then we can always give information. In the case of child abuse, we do not need consent for that. We always give information, especially when it comes to like ACS case. And then DV victims, they have to agree, except for certain cases, right? So, and I'll talk about that in a little bit. So disclosures to law enforcement. What you can give to law enforcement upon request is basic information, which they don't tend to ask us. I think they go to the clerks for this, like name and address, date of birth, and those kind of things. But for the most part, the key thing is the type of injury. So if they do come in and ask you the type of injury, you can give them a basic description of the type of injury that the individual has. But what you never want to disclose any sort of like, it says a couple of things here, but just in general, no medical records, no labs results or imaging results without a court order, which you almost rarely or ever, I've never gotten any. of the in CCT, but just in general, you don't want to release any medical records, labs, or imaging results. So mandatory reporting of injuries, as you guys know, if it's not only if a patient comes with a gunshot wound, but any discharge of a gun in general. So if a patient comes in, the story that they describe is someone shot at me or anything like that, but they don't actually have a gunshot wound, but they have soot on their person, that is reportable. You do have to get HP involved. Any penetrating wound that includes like a knife, an ice pick, like a sharp object, that has to be reported. And then another thing is burns as well. So burns that are more than 5% of the body, or burns that result in like laryngeal edema, things like that have to be reported as well to the fire department. And failure to make these reports is actually, we can be charged with Class A misdemeanor. Correct. Exactly, because it's hard for us to tell whether or not it's been discharged or if they're just carrying it. It's maybe they have like a registered gun and that's just a bullet that they're carrying in their pockets, not being actually in the firearm. I don't know, but yeah.
I encourage you to put it into a sterile urine cup rather than a bag. Some of them have jagged edges that can cut through. You don't want to get an injury from them.
Correct.
Just a question, I know this is New York painting law, and that was my knowledge of New York. Do you know how widespread this is? Like, is it every state to state?
Oh, state to state. Yeah. Yeah. These laws vary from state to state, but this is specifically for New York State. Yeah. Probably not Texas.
So if you're working somewhere else, find out.
Yeah, find out. Exactly. So just general takeaways, discharging of a firearm. So not just somebody coming with a gunshot wound is a reportable crime, right? And then you do not want to ever use the terminology of entrance versus exit wounds. And you always want to describe the location, shape, size, and the other sort of forensic characteristics that you learned about today. And HIPAA exemption allows disclosure of the type of injury to law enforcement without a subpoena. And more specifically to that, I didn't mention before, part of the work that I do with the NYPD, like on faculty with them, is that I tend to sit on some of their lectures and sort of hear what they're training their detectives on, and they're actually training their detectives to report us to the Center of Medicare and Medicaid Services, when we interfere with giving this kind of information. But of course, they're going to push it at times. They're going to push it by asking for things that they're not allowed to know, which is like the patient's alcohol level, drug level, those things. They need a subpoena. They need written documentation for those things. But if we do not give them information like type of injury, they can report us. Okay. And as I said before, if they push it, you know now for sure, you can never release medical records, including labs and imaging results, without court order.